This program is brought to you by Stanford University. Please visit us at stanford.edu.
So I also have the pleasure this morning of introducing Zahi Fayad, who really, I would say, is the world's leader in imaging the vessel wall, which is really the counterpart to what we heard here. So Zahi is a professor of radiology and cardiology at Mount Sinai and director and founder of the Imaging Sciences Laboratory there, as well as director of the Translational and Molecular Imaging Institute there, and has written extensively over 150 publications on atherosclerosis and vascular imaging, both MRI and molecular imaging and a variety of other imaging techniques. And I'd also refer you to, he has written several really excellent review articles and a recent one in Nature 2008. So without further ado, Zahi, please take over.
Great. Well, thank you very much. Really immense pleasure to be here. Actually, this is one of these cases where when you get an invitation like this and a topic that I'm not necessarily working on directly but have developed through potential collaboration at Mount Sinai and also a PhD student, Ahmed Klink, who's here working on this. So I really accepted immediately, although I knew my travel would be difficult. I just came from Vienna last night, and I feel a little bit the pain in my back, but also feel the pain with people who do this kind of travel so long. We're lucky in New York to be close to Europe in a way. But I also want to thank Mike for the invitation, as well as the organizers, and Julie White, really, who has been extremely helpful to me in arranging this little bit difficult trip. So as Mike has said, I'll be concentrating mainly on what we have been doing really with the use of imaging for atherosclerosis, and especially non-invasive imaging. But again, I think you will see this similarity, although the pathology is different, but the techniques are actually fundamentally similar. So this is in a way like an example using atherosclerosis, but you can imagine, substitution of atherosclerosis to AAA or TAA, etc. So, I mean, here being actually in the presence of the previous speaker, who's a well-known radiologist and a really pioneer in the field of imaging and anatomical imaging, etc. But we get reminded a lot in radiology that our focus has been not the brain, hopefully not, but really anatomy, and actually using MRI or CT, looking at anatomy is really the bread and butter. But I think as we move forward to the 21st century, and we also understand the disease, that is not necessarily only an anatomical feature, but rather is a dysfunction that's happening at the tissue level, but also dysfunction that's obviously happening at the genetic, the cellular, and at the molecular level. So we have to be able to interrogate, if we are using imaging, the aspect of what's occurring at that level. And I think also in terms of AAA disease, although the anatomy is important, but it's also well recognized, like in atherosclerosis, that you may have somebody who doesn't have a small aneurysm, but they still develop a rupture. And somebody actually with a large aneurysm that does not develop a rupture. So you have to be able to supplement, I would say, both genetically, which I think is going to be critical. I think also biomarkers, circulatory biomarkers would also be helpful. But if you can really add to that, I think from some imaging endpoint on top of it, and come up with some kind of an algorithm that is a nice marriage of these three things together. I think this is one of our, a lot of people in the audience here's goal, I know especially at the NIH also, in terms of the NHLBI and the direction that they're looking into. So I'll give you one slice of the pie in a way, and I'll draw a lot on features related to clinical and preclinical imaging, and Jonathan Gillard from Cambridge will talk actually more and more about the human aspect, but we'll talk a little bit about it. So when we are faced with looking at, let's say, vascular disease or atherosclerosis in general, we're not necessarily only using imaging tools, one single one, for example. That's one method that's very important. And this is actually something that at Stanford, they have pioneered the aspect of multimodality imaging, both preclinically and clinically. So you have the option. And you have a whole series or laundry list of techniques, from MRI to micro-CT to nuclear imaging to bioluminescence imaging, very familiar here. You could look at plaque in the mouse by MRI. You could look at now further, let's say, monocyte trafficking using SPECT imaging, or you could look at the cell death by using bioluminescence or fluorescent imaging. So these techniques, although they are, called the micro aspect because we've kind of tailored the imaging system to the anatomy itself, but the same also can be done in a way with some limitation, obviously. Certain techniques are not ready to be used in the human, but we have a whole series. We have ultrasound, and ultrasound for atherosclerosis as well for aortic measurement is there. And there's variation of ultrasound. I think ultrasound also has, contrast-enhanced ultrasound is moving in an interesting direction, 3D ultrasound, etc. I am not talking like Jeffrey, we ignore the invasive technique. I think it's a whole different lecture in a way. But the ones that are really emerging, and I think, repeating a little bit from the previous speaker, multi-detector CT for plaque imaging is mainly today an anatomical feature, is stenosis imaging. I'm not sure the value yet in terms of plaque characterization, but I will talk to you about preclinically some potential to take iodine and to improve on the detection beyond iodine. Magnetic resonance imaging, continues to be here because of the non-invasiveness, the lack of radiation, as well as really the manipulation. It's very rich MRI, there are a lot of knobs, and maybe that excites people, but also turns people off. That you can manipulate there's actually a famous Nobel Prize winner who said, if you treat the spins very well, you can let them do whatever you want. We have John Pauli here, who is a master spin manipulator, from a good point of view, not a bad point of view. And I will talk a little bit about taking MRI, beyond, and I think Jonathan will obviously stress this more. I'll talk about perfusion type of measurement where you can look at perfusion of tissue activity. And finally, the only technique currently we have really to do molecular imaging, and it's a technique that is commonly used in oncology, and they have actually led the way, I have to say, in oncology in terms of the adoption of imaging, is fluorodeoxyglucose. And I will show you a recent paper, actually very exciting, in AAA disease in human. I think this is a direction where we're taking. So we do live in a multimodality world. Maybe in clinical practice is different. Some people just focus on one, but I know that Jeffrey also uses other techniques in the lab. But also from a research point of view, we definitely live, so it makes it more expensive. So the NIH hopefully increased the budget, yeah, right, in multimodality imaging. Okay, so now this is a quick summary, and I will really not go in depth into it because some of it will be covered by the next speaker. But there are several versions, if you will, of MRI. There is a plain old MRI, which is focused on anatomy, and it's non-contrast enhanced. So you can actually manipulate the spins to get contrast from MRI and tissue characterization. Now, specifically to atherosclerosis, the data we have is that it has a good variability from an inter-study point of view. So when you're looking at doing power calculation and repeat studies and multi-center trial, this kind of measurement is strong in the carotid, in the aorta, and in the periphery. But is actually weak or even absent in the coronary artery from that point of view of putting it outside in the field. There have been also small studies to show that if you do some kind of a intervention, and this would be more pharmacological intervention, such as the use of lipid-lowering drugs or the addition of lipid-lowering different intensity, and Jonathan will talk about a nice study he has, but also in terms of, let's say, an LDL reducing drug and an HDL increasing drug, you should be able to see the difference. We lack a little bit here more of the large study. I'll talk to you about a study that's ongoing, give you an example. So now different flavors on MRI, and the difficulty increases as I will move forward. Now this is multi-contrast MR, and this is using now the manipulation of the spins, and this is the main focus there is there a lipid-rich necrotic core. The variability of that measurement may be 10 to 15%. It's harder to do. So then the error of the measurement is stronger. But also, I think we have seen data that looks at reduction in lipid-rich necrotic core features by lipid lowering at 18 months. That's important also is when can we measure and see the effect. That's very critical. Now an area that, again, is started or is common in oncology is the use of dynamic contrast-enhanced MRI. We've heard about MRA with gadolinium, but this is really using the data, using every possible data point and following the perfusion of that contrast within the tissue. Something we do actually in the heart, but it also has critical information that we can extract in the vasculature itself. We can get basically tissue perfusion. And with some modeling, as I will show you a little bit, we can get the aspect of what is perfusing that tissue. So neovascularization, which is an important aspect of, let's say, plaque instability, but also could be important in the AAA, obviously. It could be important. The measurement is here difficult. This is where we get a little bit that we need better computational tools, and then people develop different models, et cetera. I will show you work from a PhD student in our lab who very simple area under the curve measurement, shown in a recent study a good relationship for neovasculature. I will leave this area to Jonathan. He actually is really the world leader in this use of small ion particle and has great example of a clinical trial that he presented at the last American College of Cardiology, and we coordinated very well. No, we just coordinated just last 5 minutes this morning. And finally, I'll talk, and I will intermix a lot the use of FDG because it became a very important supplement. And it took us, actually, it's taken us to beyond anatomy and MRI is to get this activity. And I will give you a little bit the background behind this technique. I will not talk a lot about human imaging because Jonathan will do this. But today we do have actually MRI is available, is strong, in multiple centers, is able to look at the whole aorta. You can see the whole aorta in single shot here, looking at plaque accumulation within the wall at different areas. You could do plaque characterization with non-contrast enhanced MRI in the carotid artery, in the peripheral vessel, and get these non-invasive pathology. This is where you can get a map of the thrombus, of the lipid-rich necrotic core, dense fibrous tissue, et cetera. So in a way, if you have a region that's pretty thick, we're not talking about a small thickening of the wall. The nice thing about AAA, which I'm always attracted to, is that it's pretty big. Size-wise, it helps a lot. In a way, from when we talk about plaque in the carotid, we're a little bit limited. At least here, I think the anatomy is helping us. So there is a great potential of success, and I'm sure Jonathan will mention probably the work of Chris Kramer, maybe. Chris Kramer have shown, with gadolinium-enhanced MRI, good characterization of the wall in AAA. So let me talk to you, in the sense where we need to go in a way. It's a very complex disease, not unlike AAA disease. It's a disease where there are a lot of, signaling that's happening. People in vascular biology, each, love different type of molecules at different stage in their career, or some of them, argue what's important. The VCAMs, the oxidized LDL or not, but I think we have usual suspect. We don't have a single target that predicts plaque rupture, but we have, a whole, we have a little bit of an understanding what it could be. We think that inflammation is a very important aspect that initiates early on, but also leads to the cascade of trouble, as well as angiogenesis also and the formation of these vessels. So when you're talking about designing studies or looking at molecular imaging, you have several potentials at least to try, and this is the approach that we have taken. So let's talk a little bit about angiogenesis and what can you do with angiogenesis measurement. One of the things you could do with angiogenesis measurement easily is the use of this dynamic contrast and MRI technique. And this is really a technique where you inject the contrast agent, such as gadolinium, intravenously, and then you follow the uptake. You could use, two compartmental modeling in terms of following what's going on. You could use simple technique by looking at just area under the curve and trying to understand the perfusion of the tissue. You generate basically every maybe 30 second, 45 second pictures like this. You start with a pulse contrast image, and this is the carotid artery, this is the jugular vein, and you follow, how is this blushing of the contrast within the vasculature. Notice at 8 minutes, you have really a very nice enhancement, very nice delineation of the wall, very nice delineation of a separate area. This is between the fibrous cap and the outside. This is where the lipid core is. So you're starting to get just visually additional information. And if you do basically some of the kinetic equation, very simple kind of following up, and this is actually the work by Claudia from my lab, who looked at the use of dynamic contrast enhanced MRI and fluorodeoxyglucose, which I'll come back to study basically what would be the development of plaque and what kind of information we can extract. And she correlated in a rabbit model of atherosclerosis this signal intensity, this area under the curve, with the number of vessels, neovessels we have within this. It makes sense in a way. You have a tissue that's being fed by these neovasculatures, so then you should have a nice correlation between that tissue perfusion and what is being perfused. And this, I think, is exciting because this can be translated to human, because the same technique that we use in animal and in human in something that is approximately kind of clinically possible or available is to do this. So I'll come back to that as we move forward a little bit. I will not talk about another flavor of MRI, which is the USPIO. Just to say one word about it, this technique necessitates the use of a different contrast. Instead of using gadolinium as a metal, we use these iron that has a certain coating. It matters a lot in this case, the size, in terms of the pharmacokinetic. So there are little details in there. But people have shown in animal and in human, if you inject these small iron particles, they are actually very nicely end up being located deep where the macrophages are by phagocytosis. This process actually takes a little bit of time, and this may be the difficulty of application. Jonathan will give you more of a practical comment about this. But really, I think we are pretty convinced that it's a very nice relationship between the USPIO and the macrophage that is within the plaque. And I will leave this to Jonathan to talk a little bit about. Now, moving a little bit away from, obviously, from MR is the use of a different technique. And this is using positron emission tomography, and especially PET-CT, because you can't actually buy today a PET scanner by itself. You need the CT scan in a way to get the anatomy. And what's the theory behind this? If you inject a glucose analog, which is fluorodeoxyglucose, it's F18 labeled, so you could see it on PET. The idea is that these high-risk plaque have a lot of active macrophages and therefore have a high metabolic activity. And this high metabolic activity will obviously lead to this high glucose uptake. So if you inject this fluorodeoxyglucose, it gets uptaken by the macrophages and gets entrapped within there and does not get processed further. And this leads actually to the signal by FDG. So people have demonstrated, this actually work from my colleague Ahmed Tawakkul at MGH. We're actually collaborating together on a half a dozen trials right now, where he demonstrated in carotid atherectomy patients. So it's a nice system to work in because you have the pathology after the surgery. He has shown, doing the histology and comparing the imaging, that there's a very nice relationship between the inflammation as assessed by percent CD68, a marker of macrophages, and the target to background ratio that you measure by FDG. So this is a nice relationship between the two. And there's also no relationship between smooth muscle cells. There may be a signal coming out from the smooth cell, but it's not really correlated. So what we measure by FDG is really glycolysis, but that glycolysis is reflecting the milieu of the macrophages that are in there. What's even more exciting in the recent report is that this signal can be modulated by known therapy, such as the use of LDL reduction therapy and statin. And what's even more important is that reduction can be measured and can be seen very early on after treatment. At 3 months, this actually is probably the fastest, time that we're able to measure, maybe USPIO, I guess, around the same time. So you can see here, after the use of simvastatin 5 to 20 milligram, you can see now a baseline imaging, baseline, and then post-treatment, the artery in the carotid got much quieter. So this is why there's a lot of excitement in the potentially using this to follow different type of drugs in terms of cardiovascular treatment. Now going to more of a recent paper just came out actually by the group at Munich, August 2008, studying a patient with AAA disease, but also having the chance to look at the pathology and showing the thrombus here, actually not thrombus, the AAA, inflammation, FDG, very high signal within the aorta, and a higher signal in symptomatic patient compared to asymptomatic and the control group. What's also exciting is that we had pathology here again. So the Munich group did several histology measurements focusing on elastin, obviously, collagen, but also on the important aspect such as MMP2 and MMP9 with a nice correlation between the FDG signal, or the SUV in this case, as well as CD68. So similarly, as people have found in the carotid artery, there is a nice correlation between CD68 and the AAA disease in symptomatic patient. There is an MMP within the wall and the AAA disease, and there is an inverse relationship between collagen, again, and the FDG signal. So this is really exciting, I think, and this is actually maybe the first report. I asked Ahmed to do the literature. Hopefully he's right. So this is really exciting in a way to potentially supplement and move us a little bit from the anatomy, maybe MRI and FDG, and therefore my interest now in this area, and that's why I came here to learn. In terms of now the field itself, in terms of the use of MRI for atherosclerosis as well as FDG PET, what we have lacked today really is these large studies that are done in a multi-center setup. There's a lot of single-center work, but now we are actually we just actually finished recruiting from this study that is studying the effect of a CETP inhibitor that is supposed to increase HDL and lowers inflammation. This is a multi-center study done in the US and Canada using MRI and FDG PET. The same technique as I showed you here. So really we are putting the whole experience that we have now within these 14 sites. And so far, the result I don't know, but at least the experience have been good, both in performance of the MRI and the FDG PET. Now, what is lacking here, and I think this would be important also, is what is the relationship between these imaging features, either on MRI, on CT, or by ultrasound, and events? And we have not really had, although the NIH has the Framingham study, we have the MESA, but these are done in very low-risk patient population. And this is the design. The NIH wanted to look at subclinical disease. But the problem with this is that it takes a long time to accrue the type of events that you need. And MESA is now up to year 6, maybe, or year 7. And I believe also Framingham also has been second or third generation going on. So what we tried to do in this initiative, which is called the high-risk plaque initiative, is to study a little bit higher risk patient and try to compare multiple imaging modalities, as well as Framingham risk scores, simple tests such as ABI, CT coronary calcium, etc. The issue of the truck is interesting, is because now we're doing this in a single place, in a parking lot, where the whole patient or half of the patient cohort is actually now in Chicago, doing in the parking lot the CT, the MRI, and the ultrasound. So we've actually minimized this multi-center aspect, coordinating and doing all this. And even the technician will be moving with the truck to the second geographical area, which will go into Miami. They won't let me drive the truck. I'm still trying to do this. I would love to do this, but actually I'd like to move Miami too, but not working. So we're looking at about 7,300 patients. 6,000 of these patients will undergo a series of imaging techniques. Not all of them. Maybe the initial group will get the simple tests such as the blood test, the ABI, CT calcium, and corneal ultrasound, and then we will select from there the one that had positive imaging on that. And then we'll make more sophisticated imaging, such as contrast-enhanced CT and MRI. And finally, the last group will get about maybe 200 or 300 patients will get an FDG PET. 1,300 of these patients will not undergo imaging. They'll only undergo the initial aspect screening. And then we'll monitor. What's important there is the healthcare economics aspect, the use of healthcare from these patients compared to the other one. Will they end up consuming more healthcare compared to the ones that don't know the result? This is actually exciting because we're talking again about these high-risk patients. We have about 2,000 patients now into the study. And then I think Miami will probably get the rest of them in there. And we want to try to compare the risk over a 3-year period. And now I will talk to you a little bit about, share with you my family album. No, I'll talk to you about the use of molecular imaging. And really the aspect there is the aspect of payload. In terms of doing imaging, especially by MRI and CT, can you really be sensitive enough? And one of the way to do this is a very simple concept which relates to candy delivery, to actually delivery of a large amount of contrast or drug to a site of interest. So I asked my daughter, who's now 6, but I asked her last Christmas, if you have a ball of candy in front of you, we'll be taking it one by one, or you have a different technique. She said, oh, no, it's obvious. I'll just take the whole thing and I stuff my mouth with it. And I said, can you show me this? And she did. She understood payload delivery. It's this thing, and actually she also told me, I've also saw a paper in Science. I'm like, whoa. She said, yeah, they have this candy in a ball, and actually it's true. There was a paper in Science that looked at the distribution of these ellipsoid. How much can you really pack them in an orderly fashion? I'm not sure what she's reading, but I'm a little bit concerned. So really, why is this important? And let me repeat this, is that, okay, I have 5 more minutes. Oops. So why is this important? Because if we are using scintigraphy or radiopharmaceuticals, we will not be needing this delivery aspect. I think we are so sensitive, we inject such a small amount of contrast in this technique because they're really sensitive. But if we now want to use MRI, CT, we have to improve that sensitivity. One way to do this is to get into the aspect of payload, is to try to create some kind of a small delivery system that takes all this contrast agent and delivers it to the area of interest. So if you have an area, or if you have actually a target that is expressed in high enough concentration, and I'll pick an example here that could be of interest in AAA, like MMP, or even thrombus, your strategy of imaging and molecular imaging will be different. Yesterday, I think Ahmed gave me a report that somebody talked about optical imaging and MMP. But in also MRI, I think we know that in plaque, MMP expression is fairly high. So now if you have a broad MMP inhibitor, such as here with this technique, an MRI called P947, we've shown here in the rabbit model that we can image these MMP distribution. But when you don't have this, and you're looking at features that are smaller, such as macrophage density, which is smaller in terms of concentration, you have to resort to this payload delivery system. We have focused on this lipid-based nanoparticulate system, looking at different features such as alpha V beta 3, oxidized LDL, macrophages, iron oxide, multimodality, et cetera. So I won't have time to talk to you about all this. I'll give, and in the Nature paper that Mike alluded to in February 2008, we give a little bit, a limited review of literature of this. Let me talk to you about 2 examples here, one based on CT, because we think CT, we agree with the previous speaker, CT is really the only technique today that we could do very nice coronary imaging with it. CT, as you have shown, has a nice spatial resolution, only if you could do better with CT. So can you take CT from anatomy to molecular? That's a challenge we have. So what we have done is we've taken the same iodine molecule that gets injected into the clinic, And we modified it by adding this susceptible group, which is an ester group that gets cleaved by macrophages. And we've demonstrated last year that this is actually very useful, not only for an angiogram, it's iodine. So you will have a lumen iodine imaging. But if you wait 2 hours for that to circulate, you have cleavage of the macrophages and specific macrophage imaging as shown here. We've done a lot of histology imaging, elemental analysis to prove that this agent is being uptaken by the macrophage. So that's one way to potentially, there are other material, actually the Stanford group have published on some other CT variation in terms of how to make it more molecularly targeted. And now in terms of MRI, we use these lipid-based nanoparticulate system. I'll show you an example where we're targeting the oxidized LDL using these small micelles. They are small. They are maybe about 20 nanometer or so. We can modify the surface of and do a very nice chemistry to try to conjugate an antibody here. This is an antibody that gets recognized by the oxidized LDL, as shown recently. And we show here in a pretty extensive study just published this summer in Circulation, imaging of oxidized LDL using the MTA2, the IK17, and the EO6. All these are small antibody fragments. This is in collaboration with Sam Semikas at UCSD, showing also control experiment that we can measure specifically and co-localize our targeted approach to the CD68 or the macrophages. And one final platform that we feel very excited about is because it's biomimicry. We're using things that the body uses very well, to use them as carriers. Lipoproteins are well known, an endogenous nanoparticle. They're involved in cholesterol transport, especially the high-density lipoprotein. And there are very nice techniques in terms of modification and reconstitution of the HDL, both non-synthetically from human blood and synthetically. There are known peptides that mimic exactly the HDL. So what we have done in this work is done modification of the HDL, not only to put a gadolinium on the surface, but actually this year we had a breakthrough where we can modify the whole, the inside of the HDL. Oops. And this is my end of my talk. No. So we can put a gold particle inside of the HDL, so we could have CT imaging. We could also modify the inside of it to put an iron particle, as well as a quantum dot for optical imaging, etc. You can use them singly as a single modality, but also you could use them as a multimodality approach. And this work by David Cormode that is under review, looking at MRI imaging in ApoE knockout mouse. This is now showing you just the MRI picture, but this agent is labeled with both gadolinium and and gold. This is gadolinium and quantum dot. This is now iron oxide imaging showing macrophage-specific uptake. There's a lot of peculiar or interesting feature of using almost a natural type of particle, because you get away a lot from the immunogenicity and you manipulate a little bit the system and mimic the biology directly. Let's skip this. So finally, one more thought, and this is going back to the family album. And this is now Chloe you've seen, and this is Christophe. He's 2 years old. And she has different views than him, obviously. But what she does is she tries to manipulate his views to get him into trouble. So, different views. So, all right. So this is a different view now. Now, our view here is, why are we only imaging? We have a nanoparticulate system. It is a contrast imaging or contrast delivery system. Why not use the same setup to deliver a drug? This is just an example, and I'm not pushing glucocorticoid, but there may be something in there. So we know, for example, we take glucocorticoid as a drug, and glucocorticoid have been shown to have anti-inflammatory effect. When you inject glucocorticoid systemically, there are a lot of side effects because the dose that you need to inject usually is very, very high. They have very poor bioavailability. So why not actually encapsulate the glucocorticoid inside of the delivery system and do targeted delivery, where now you are injecting very small amount of drug because you're accessing the area of interest and much better because of the better pharmacokinetic you have. So this work is done led by actually Willem Mulder, a faculty in the Imaging Institute, as well as collaboration with Gert Storm in Utrecht, where we use these liposomal system. We load, let's say, the glucocorticoid. These liposomal systems are pegylated, so they have a higher circulating time. And using the same tools that I explained to you before, again, a multimodality approach, Willem has shown that both by FDG PET and by dynamic contrast enhanced MRI, as well as because he's labeling the liposome with gadolinium, he can see the delivery that's occurring really in there. And people who are doing interventional MR imaging and other know that it's important to monitor, whatever you inject or whatever you don't, and use the imaging to help you, not only to read the effect, but also to understand better the delivery. So what's really exciting about this is with a single injection of these liposomal glucocorticoid, Willem has shown that only 2 days after, we have an incredible reduction of inflammation, as shown both by FDG. This is actually showing you now one injection, you wait a week, 1 week only, suppression totally of the FDG signal, and there's a very nice change in the angiogenesis after the delivery. This is actually very exciting because now we have to understand how long we need to do this, the frequency, but really show you a rapid response from the drug, but also we can measure that by the imaging. So if you want to hear more about what I talked to you about, maybe in slightly more detail, I again turn to this February 2008 issue, but there's not only this article is interesting, actually it's probably the least interesting. This issue has very nice papers, obviously, from the histology of atherosclerosis, but very nice also technique looking at proteomic, and really you see the whole spectrum, genetic, proteomic, and disease in a whole single issue. So it's very exciting for people here. So with this, I like to conclude, but I have to obviously, this work is done with long-time collaborators, especially one of my chiefs, Valentin Fuster, who recruited me to Mount Sinai, as well as Michael Furcu, a cardiologist at Sinai who leads the clinical trial unit, where a lot of these concepts are being tested, as well as Ed Fisher, well known to some people here in the audience, who has been my longtime collaborator when he was at Sinai, but even across the Central Park, we still collaborate, and we continue our 11-year collaboration. Many other people funding, but really the people in my group who've done and continue to do, I think, very hard work. I hope they're working right now, but I know one of them is not. But really, this is tribute to them. A lot of their effort and energy went into this. Thank you very much. How are we doing time-wise?
Thanks, Zahi. That was really a tour de force. And I think from what we saw yesterday, the number of overlap, or the number of areas that overlap between inflammation, angiogenesis, MMPs, between atherosclerosis and AAA disease, while they clearly have substantial differences, I think the progress that you've made in identifying these biological components in the vessel wall by studying atherosclerosis, I think are highly and directly relevant to trying to develop the same kinds of studies so that we can migrate to patients for AAA disease.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.